So John, you were putting out a call to action for folks to, within this group, work with OpenNotes in a national way to reach out to these vendors to improve access to notes, everything you talked about, the tracking, how do we even measure if patients are reading notes? How do we even know if this is helping patients if they're not reading their notes? And so there's this EPIC strategy and a Cerner strategy and potentially other strategies depending on different vendors. So some folks raised their hands, like Cindy Kelbs from Rady Children said, we're interested. Paul Fu, who's at, where are you now, LA County, said you were interested with Cerner. So feel free to chime in, anyone that we'd be interested in your reactions on this. LA County, got it.
Yeah, I mean, Liz, generally what we find with vendors is they're respectful to us, but they don't do anything for us because we're not customers. Mm-hmm. If we get one customer, it helps a bit. But if we get multiple, then we see some action. That's certainly what happened at EPIC. And we've had some success at Cerner, I think, when multiple customers have urged that a change be made.
I know some. Oh, go ahead.
Hi, this is Chetan. I just wanted to say, I think focusing on read rates, on if notes are viewed, is definitely a really important metric to look at, because I think for systems that are implementing notes, it gives important information into whether or not it gives important information for health systems to see how their notes are actually being used. But I would also say it's not the I think what we've learned from some of the anecdotal OpenNotes experiences and feedback, it's not always about reading notes right then. For example, a patient might have a note after a visit, and then it might be like a year later when something comes up that they need to refer back to that note to really understand what happened then, whereas reading it right after a visit might not have been as helpful. And to go to Betsy's anecdote, she mentioned how she and her daughter read a note before a visit to prepare for the visit. And so I think while looking at read rates or note viewership is an important overall quality metric that we should be able to go towards, I think understanding some of those nuances of like when notes are read, is it before a visit, after a visit, is it to have so you can refer to later in the future, so I think just wanted to raise that point as well.
Well, yeah, so an important one. I think we would agree that the note opening rate is crawling. It's not even walking. It's a process measure. It's, I think, good for the situation we're currently in. But there's much more meaningful stuff, as you mentioned. I mean, wouldn't it be great if we could measure how many times are notes being looked at for an interoperability purpose? As many of you all said before, to show to a primary care doctor or specialist, or to doctors while you're traveling, how many are being seen by a caretaker who has that this is the only way that they can figure out what's going on. We're actually having a discussion like that in our national HIT PFAC, and have a subset of patients who are suggesting ideas. And one of the things suggested in general is, can we measure what happens after a person reads a note? Where do they go? What do they do? When I was at Consumer Reports, I just couldn't believe how much measurement there was going on. We knew where they came from, where they went, and we were really able to track what our customers were doing, and so we could figure out which of our content pieces was the most effective in getting people to do things that we thought were proactive. Absolutely right, and we're very interested in any ideas anybody has about really how do we walk and run. You're absolutely right.
as a research project slash movement, OpenNotes is not a client of the major EHR vendors. So there are many of you on this call where you have power to talk to Epics and Cerners and all the Allscripts and request changes or to make access and use the usability of your portal, more friendly to notes that we can't. We, of course, when we talk to those folks, we say, can you make it more easy to find notes in my chart? And they're like, well, you're not one of our customers. So that's why we really try hard to make, develop partnerships with folks at other organizations who might be interested in working together to make these changes.
So, one of the things we've talked about, and some of you all have done research with Epic and other vendors, is, sometimes the vendors have a data which answers questions that they can get at fairly easily. What we need to do is figure out what question do we want to ask and which organizations would give us permission to get their data from Epic, or give Epic permission to put their data into an analysis of some sort. Because Epic does know who's sharing notes and who's not, and how many notes are being shared, and I think they do know how many notes are being opened. It's now going to be on their dashboard. All of you with Epic are going to be able to easily see that, so they're going to be able to figure out how well they're doing as an organization. So that's another thing that we could do.
So I'd say at this point, I'm going to open it up back for all of the questions. And there was something that was asked earlier, I think during the Rady's presentation. Andy Spooner said, Andy Spooner asked it about the Stanford presentation, Chafin. He says, looks like 1 in 6 patients at Stanford Children's raised a question to their provider based on what they read in a note. It seemed like a high rate. How do you manage such a high volume of messages or calls?
Yeah, I did see the question, and also I saw a response from John sharing data from Segal of this concern that comes up where if you get a question about your note, how do you respond? How much resources is that actually taking up? And for us right now, this was just based on this one survey. In anecdotal conversations with different clinics that have been live with OpenNotes, haven't heard that coming from the clinicians saying that they're getting too many calls or requests. Because I think with that question, what it doesn't really delve into is how they contacted their clinicians. So some of them might have contacted through MyChart. Some of them might have contacted their physician at the next appointment too, right? It could have been there was something in the note that they saw, and then maybe they made an appointment to discuss it in person. And we also don't know the full range of issues that have been brought up, whether it was a misunderstanding that could have been an important patient safety issue, or whether it was something more minor. And so I think it's a fair point that does come up from time to time, and I think it goes beyond just OpenNotes. As we move into a world of increasing digital communication with clinicians, where it's not always about communication at the in-person office, where it's communications that are happening asynchronously at any time of the day, with things like telehealth and virtual visits, we're going into this new world of care delivery. And so I think there's a lot of changing that's happening, and so I think it's all part of that context. But I think overall we haven't heard that from the clinicians directly, that it's been overwhelming with being flooded with too many calls. And I think, as John pointed out in his response, there are different ways of addressing this. If you do have a lot of calls coming in at your institution, you can set up a triage system. I think there's a paper about this from Boston, from some of the Boston area hospitals, where you can have a hotline, an OpenNotes hotline staffed by a nurse or medical assistants who can triage the calls, and depending on what the call is about could be sent to a clinician or can be referred to follow up later. And if I remember correctly, from that paper, when they did use that hotline system, around 7 to 10% of all the calls were actually regarding a serious error that needed to be addressed right away. So I think those are some of the issues to consider around the space and some of the strategies for moving forward.
Yeah, there's a lot of focus of, wow, we're going to have this workload increase because patients are reading notes, and there are folks who are setting up strategies to, okay, how are we going to deal with that? But the majority of organizations say, wow, it was a non-event. We opened the notes and no one read them. And along with that, we opened our notes, we didn't get this overwhelming flood of questions and phone calls and emails. And then along with that, now we see with John's report, well, people might not be opening their notes anyways because they didn't know the notes are there. So we're kind of in this interesting catch-22. So Shobha is asking a question. Shobha is at San Francisco Department of Public Health, and they have yet to launch their new version of Epic. I believe that they're doing it this fall, crossing fingers, and are considering going live with the new version of Epic and OpenNotes at the same time. So Shobha is asking, for Cindy and Chaitan and any others sharing notes, can you talk about what type of education you gave to pediatricians about scenarios in which pediatricians should not share notes with adolescents or parents?
This is Cindy from Rady. Yep. We had a lot of discussions about what is legally necessary to not share with a parent relative, as we spoke about, to the reproductive health requirements. But with the not sharing notes with sensitive issues, we didn't. We talked about it and talked about different scenarios as to what should be sensitive. But I think the problem with it is that some people are more worried about sharing notes than others, and what's sensitive to what shouldn't be shared to one person may be fine with another. And so we did talk about how to frame issues. So rather than saying that the parent or the patient is malingering or fabricating, to state that the symptoms that the patient describes aren't matching the signs or the results or that seen, or if the parent or the patient is perceived as difficult to say, or sometimes somebody might describe them as kind of aggressive or belligerent, to say, parent, we discussed these things and the parent was frustrated or about the conditions and had many questions or that. So we talked about how to reframe some things so that it would not be perceived as pejorative to the patient or the parent.
And Shobha, it's a good question. So for us, two things on that. So one, we haven't been sharing notes with adolescents just yet, but have been having conversations with different clinicians around different concerns that might come up. And one of the things that does happen typically with adolescent documentation is that there might be sensitive information within a note, even though the whole note is not sensitive. There might be certain sections that are sensitive. For example, in a primary care pediatric visit, there's an acronym called HEADS, HEADDSS, which is really kind of talking about the home, education, but then talking about issues of drugs, of sex. And those are things that are typically documented separately in a separate section. And those could have different settings in terms of how they're shared. So there's a lot of education that has already happened even pre-OpenNotes, and every institution has different policies around this. Every state has different laws around this. Some institutions will actually document the sensitive HEADS exam part on a piece of paper that's not actually in the EMR and gets scanned in separately. So there is a lot of education around that already happens. And then in terms of more specifically what we've done, since we took a department by department approach, I met with I went to the department faculty meetings for a lot of different departments and started to understand what the unique concerns were in one department versus the other. And they were often very, very similar, whereas an individual department, for example, like plastic surgery, they felt that in their documentation, they might write that a procedure was cosmetic, even though a patient or family member might not believe that it was cosmetic. And it's the same idea that there might be disagreements between what a clinician might think and what a patient might think, but ultimately notes are not really the place to kind of air out disagreements, but really a place there could be differences, but really a place for people to understand the different perspectives and come together. And so, yeah, I think it's a good question. There still needs to be more work, but I think the first challenge is in building a note sharing system in which we can have greater granular control so that a note could be shared, but make it obvious that certain things like certain medications or tests are automatically not shared. And having that finer granularity would, I think, be really reassuring to many clinicians who are concerned about adolescent confidentiality.
Thanks on that.